power-assisted liposuction. You see how the tip vibrates, so I don't have to be jamming the instrument back and forth. This is similar to an electric toothbrush where, you know, you don't have to be very, very forceful, because that's how you get gum bleeding when you're brushing your teeth. And the same thing applies here, right? Can you show them what's coming out?
Yeah.
So what's coming out is yellow, beautiful, bloodless fat, right? And that's what's going to go into her buttocks. So that's very important, that the fat graft that we're getting now is what's going to go into her buttocks. So when we put this into her buttocks, it's going to look exactly like that. Yellow, bloodless fat without any oil. Why? Because we don't do aggressive liposuction. We don't put the machine at full force, so we lower the aspirator to less than 18 millimeters of mercury, so that we don't damage the fat cell and the oil does not leak out. If you have oil and you put oil into the buttocks, the body is going to reject it, and that's going to create a capsule around it, or a callus, much like it would a foreign body, like a piece of glass or a bullet. It's going to reject it, and it's going to push it out to the surface, and that's going to look like a tennis ball or maybe even a volleyball sticking out of the bottom, and it's that oil that is being rejected. In the same fashion, blood is irritating to the tissues. When the blood is outside the blood vessels, it irritates the tissues, and the body rejects it in the very similar manner, similar to what happens when you have breast implants and you have a little bit of blood around the implant. The body rejects that blood, right? And it creates a capsule around the implant, right? And that capsule can get thick, right? And start squeezing that implant and eventually break it or deform the breast. And that's what is called a capsular contracture. And one of the theories of capsular contracture of the breast is precisely a lining of blood. It's not a hematoma, it's not anything that's going to need a blood transfusion or reoperation for bleeding, which, by the way, we never have to do, but more just a little bit of blood around it. And I contend, my theory is that the exact same thing happens here in the bottom. Those famous blowout fractures and oil cysts are no more than a foreign body reaction, especially when the surgeon destroys the connective tissue in the area of the superficial gluteal space. And we usually put the fat graft in the deep subcutaneous space, but if you put the fat in the correct place but then destroy, say, the ceiling of that space, which is the superficial gluteal fascia, that superficial gluteal compartment or space is much less compressible because it has a lot of connective tissue. And so that fat graft that you put in the correct place may herniate through holes made into the superficial gluteal fascia and migrate, and that is what can probably give you the famous blowout fractures and oil cysts, and something that we want to avoid at all costs, right? Thank you. Okay, so also look how comfortable I am. This is very comfortable also for the surgeon. Much less risk of having occupational injury in the form of tendinitis. I'm not sweating it, right? So much less risk of contaminating the patient as well. And much less risk for the patient, of course, of intrathoracic or intra-abdominal injuries, right? Why? Because look, My strokes are very calculated, right? Very, very slow, right? I'm not rushing it. I believe that what happens when the surgeon has a injury in the intra-abdominal or intrathoracic organ injury, it happens usually to a surgeon that's already fatigued from doing multiple cases, maybe, 10 cases or whatever. We only do 1 or 2 at the most, right? So the surgeon is rested, right? It's much like driving, driving a car, at night when you're tired and going at full speed. You may lose situational awareness, right? You may lose the air control of the vehicle and go into an area that is not, where you want to go. Thank you. Yeah, so situational awareness. Our dear friend Dr. Gabriel H told me, in the next WAC meeting, World Association of Gluteal Surgeon meeting, ask the surgeon, when you flew in here, would you like your pilot to use instrument? Or just go by sight, right? So and that's because when we inject the fat graft into the buttocks, we are going to use instruments. We're going to use basically what is called the ultrasound. Like when you have a baby, you can see the baby, right? Sucking the thumb or whatever. We do the same thing here, and we're going to show it to you so that the surgeon doesn't lose situational awareness. Thank you. So right now I'm using my non-dominant hand, so that is how you prevent also occupational injuries, tendonitis to the surgeon, because we can decrease it basically by 50% if you use both hands 50% of the time. Thank you. Defined very nicely on both sides, and the midline right there. The buttocks are over here, but we do high definition on the back side as well. See the paravertebral muscles right there, right? Thank you. It's good, huh? Alrighty, so notice the fat graft, how pure it is, the way it came out, that's the way it's going to go in. I'm looking at the patient, I'm looking at what's going in, without a drop of blood, without any fat, oil, the fat graft by itself without oil, and I'm looking at the ultrasound to put it in the correct place. We're teaching doctors how to do these through the World Association of Gluteal Surgeons. We have multiple workshops in the United States and abroad. So if you're interested in doing this in a safe manner, please give us a call here at the World Association of Gluteal Surgeons, or you can call the Cosmetic Surgical Center of Lazarillo. Thank you.
All right, we're doing ultrasound guided gluteal fat transfer. This is the patient's skin. This is the patient's superficial gluteal fascia. Down here we have the deep gluteal fascia, and in between, in this deep subcutaneous space, which is where doctor wants to be putting the fat, we have Dr. Patino's cannula right here.
And I'm going to wiggle it for you so that you can see the actual cannula. I'm withdrawing it, you see, and I'm wiggling it. So you can see the tip right there. And I'm going to give it a bolus, right?
Right.
So you're going to describe what happens.
Okay. So what he's doing right now is putting a bolus of fat into the deep subcutaneous space, and we can see the gray is entering into the area, and the deep gluteal fascia is getting pushed down. The superficial gluteal fascia is getting pushed up as fat enters this deep subcutaneous space.
And that gray cloud is fat,
Right.
graft. Thank you.